Hello, everyone. Welcome to BIOMES. I am a PhD student at YSE, and I'm Hannah. So BIOMES is a community-sourced seminar, and we always welcome any speaker suggestions. So please let us know if you have any speakers specifically in mind. And today we are going to welcome Dr. Chen. Dr. Chen is an environmental epidemiologist who focuses on the intersection of climate change, air pollution, and human health. His work involves applying multidisciplinary approaches from climate and air pollution sciences to exposure assessment and environmental epidemiology to investigate the impacts of climate change on human health. Dr. Chen investigates how ambient temperature and extreme weather events, such as drought, floods, wildfires, can affect mortality and morbidity from a comprehensive spectrum of diseases, including myocardial infarction, kidney disease, childhood diarrhea, birth outcomes, unintentional injuries, and mental disorders. He also assesses the adverse health effects of air pollution and their interactions with extreme temperatures from a local to global scale under a changing climate. With that, the floor is all yours.
Thank you, Hannah. So it's my great honor to be here as actually formal training students, undergraduate PhD in the school environment. So I actually be very excited to be presenting here at the YSE. And today, I want to offer some what we call the silver lining when we think about the climate change. That is using the tool, the discipline, we call it climate epidemiology. And I do hope through today's talk, when we think about the silver lining, whatever, regarding the election results. So how do we assess the health effects of climate change? If you look at the global surface temperature since the Industrial Revolution, and over the past few decades, it's been crystal clear. Global average temperature is increasing, with the year 2023 being the warmest year on record. And with this year, multiple months, the summer being the warmest year on record, 2024 is on the track to become one of the warmest year again. So with a warmer climate, obviously we have more heat waves. But in addition to that, we have a lot of extreme weather events, like devastating wildfire events happening in Lahaina, Hawaii. Or last week, we see the deadly flash floods events hitting Spain. Or here, showing one of the largest freshwater lake in China. It was basically, there's no water there during a severe drought in 2022. And then there's more, right? We have two major hurricanes hit back to back to the US. Because of climate change, these hurricanes are becoming more windier, and also become more destructive. So what are the health impacts from climate change? Well, climate change, on one hand, can directly impact our health through these extreme weather events, but also indirectly through worsening our water quality, air quality, land use change, or ecological system changes. And all these direct, indirect changes combined together, they intertwine with what's happening in our social dynamics, population aging trend, social economic changes, etc. Everything combined together, they can impact not just our physical health, but also our mental health. So actually, a decade ago, Lancet has a commission on health and climate change. And the expert actually made a statement saying that climate change is the biggest public health threat of the 21st century. And today, with what we have seen for the COVID-19 pandemic, many experts believe this is still the truth. But if you call it the biggest public health threat, then the question is, how do you actually quantify its impact? And the tool we're going to use is a new kind of sub-discipline from epidemiology. What do we call it? Climate epidemiology, or climate change epidemiology. So basically, is apply multiple approaches from different disciplines: climate science, environmental science, exposure assessment, biostatistics, public health, etc., to try to understand how climate change impacts our health. And here at the Yale Center on Climate Change and Health, which I'm fortunate to be the co-faculty director, and specifically at our lab, the Chen lab, the Climate Health Environment Nexus lab, we aim to apply all these different multidisciplinary approaches, try to look at health effects, air temperature, extreme weather events, and air pollution, and a changing climate. And if we look into this field, over the past decade, the field has been growing exponentially. And if you look at all the current activities, and we can classify the current research directions based on what I call a framework of health impact assessment. So for example, if you want to assess one climate-related risk factor and to project or to estimate its health impacts, the first thing we want to know is what is your study population, right? Study area, study region. And second of all, what is the climate-sensitive health outcome you have? And what is the baseline rate? The third one is the expected changes in this climate-related risk factor or exposure under different climate scenarios. And last but not least is what we call the exposure response functions, basically linking the exposure and your health outcome. So that's actually what we epidemiologists do all the time. And when you have every pieces together, you can project in the future or look into the back to see what's the health impacts of climate change. So therefore, I think we can classify what the activities in the current climate epidemiology. The first one is to look at the understudied peers of climate-related exposure and a certain health outcome to quantify the exposure response relationship. In other words, we call it association studies. So this is a major task for people in the epidemiology. The second one is if we look into the expected changes in exposure, but looking at what the alternative universe, what the Earth would be if there's no human-induced climate change, then we can calculate the human-induced climate change contribution to the historical public health burden. And that is what we call attribution studies. But if we look into the future, based on multiple global climate models, different scenarios, different projections on social economics, on population, what we can do is we can reasonably quantify the potential future health impacts, right? So this type of study, we call it projection studies. So from now on, what I'm going to do is to showcase some of these research using our own labs research examples to illustrate these three directions. First, association studies. I think I will just start with everything, probably have in mind air temperature, right? Because all the time we talk about is ambient temperature has been increasing. So when you think about the health effect of air temperature, without going literature, what we experience, when we know too hot or too cold, people feel discomfort, right? So from decades of temperature and epidemiological research, what we have known is that the association between temperature here, for example, on this x-axis, and the mortality risk on the y-axis, you basically observe what we call a U-shaped relationship. That means when temperature goes too hot or too cold, it kills people, right? But also from this curve, what you can observe is that the heat exposure doesn't need to go to the 99th percentile to kill people. When it goes to, let's say, 80 percentile, 90 percentile, it also kills people. And more importantly, because these are extreme weather events, it's extreme temperature, you only have less than 1% of days exceeding the 99th percentile, right? So we have way more days experiencing this so-called moderate heat days or the moderate cold days. So that is important because when we think about the overall health burden, so this moderate heat and cold combined together has much larger impact in the final health burden. Then if you look at this, then heat kills people, but how, right? So how does heat exposure can actually lead to this substantial increased mortality risks? Well, we may get some insights if we look into the different cause-specific diseases and to see if there's any connection there. For example, when we look at cardiovascular system diseases, we look at what we call a registry data that basically you look at all the people in a location and follow them up for a long period of time. So here we look at a small German city called Augsburg, and we track everyone that has heart attack events. And what we observe is similarly, you have this kind of U-shaped relationship, right? So when temperature goes up higher, you're going to have more heart attack events. And recently, led by our postdoc fellow Lingjie Chu, we look at this issue in the US using a commercial database. And what we found is that among young adults that aged 18 to 64 years old, you see almost universally increased risk for people having stroke when you have a higher temperature exposure. So these are just two examples we show that heat can have substantial impacts on the cardiovascular system. But the adverse health impacts of heat goes beyond the cardiovascular system. To just give you some quick example, very recently, Professor Tom Rogan at the School of Public Health, we conducted analysis to look at the childhood leukemia cases by linking the birth records in California with its cancer registry. What we found is during pregnancy, the temperature exposures could also lead to significantly increased risk for childhood leukemia. And working with Dr. Yu from the State University at Buffalo, we look at all the emergency room visits in New York State. What we found is universally you see an increasing trend that when temperature goes up, the emergency room visits for mental disorders increases. And if you dive into the different causes of the mental disorder, whether it's anxiety disorder, mood disorder, schizophrenia, or even dementia, you see an increasing trend. So this really illustrates that the heat effects goes beyond just the physical system, physical health. And what about the extreme weather events? So our group recently completed a project using the data from the Demographic and Health Survey. What we found is among about 50 low and middle income countries, long-term exposure to drought, for example, the 6 months drought exposure, could lead to significant increased risk of childhood diarrhea among children under 5 in these low and middle income countries. And in another analysis, what we found is that a few weeks exposure to flooding can also lead to this significant increased risk for childhood diarrhea. And more interestingly, if you have a drought first, followed by a flooding event, that flood going to have much larger risks compared to just the flooding events. So this really illustrates the adverse health effects from the compounding events. So when we think about the extreme weather events, drought, flood, wildfire, they do not act alone. So when they interact with each other, and they can have these co-occurring compounding risks that are potentially larger than each one combined together. In terms of flooding, well, it also hits home, right? So if you recall the news, Hurricane Helene, the major fatality actually comes from North Carolina with the associated flooding after the Hurricane Helene. And we actually did a study last year, try to see if there any connection between flooding exposure and the cause-specific mortality in North Carolina. And if you recall the news, when you see unfortunate news that people died during the flooding, it's usually drowning or when they're drying or tree falling, etc. This kind of accidental mortality, right? So in this study, we look at the flooding exposure, a few days flood exposure are associated with increased risk, not only for this kind of accidental mortality, but also for non-accidental mortality, such as cardiovascular disease, respiratory illness, and even mental health mortality. So this really reveals what we call the hidden burden of flooding, because over the news, what you hear is only fatalities from direct injuries. What about the indirect costs, the indirect deaths? These are potentially much larger. And our calculation shows that if the association we found is true, in North Carolina, every year you will have about 200 people die because of flooding events. So that number is way larger than what has been recorded when we look at the major flooding events. Here, this figure, you may recall this, right? The sky in New York City last year in June 7th turns orange. And the reason behind that is that we have the Wi-Fi smoke hitting New York, the east coast, traveling hundreds of miles from the east Canada. And on that day, New York City had one of the worst air quality among all the cities, and the PM2.5 level reaching about 150 microgram per cubic meter. So working with Professor Bell, we quickly did an analysis to try to see what are the health impacts. So we look at the emergency department visits in New York City throughout the different boroughs. We found consistently a significant increase in the asthma-related ED visits by more than 40% during this 3-day smoke wave. So last year's event is a reminder for us that Wi-Fi smoke is not just a Western US issue. It hits us here as well. But we actually know that well before the Wi-Fi smoke event. When we look at the Wi-Fi smoke across the United States, because the smoke can actually travel hundreds to thousands of miles away, we do see a lot of impacts in the middle of the US, especially and as well as the southeast. They also have a lot of burning, although they didn't make the highlights because they are not mega Wi-Fis. So we did the analysis and estimated that roughly about every year, more than 11,000 deaths could be attributed to the long-term exposure to the Wi-Fi smoke. And among that, the biggest contribution is from cardiovascular system disease, mental disorders, and endocrine diseases. So this work is led by former PhD student Chen. But in this study, one interesting thing we found is that if you have a Wi-Fi smoke exposure, on the same time, if it's a summer heat, you have the co-occurring extreme heat events happening. When these two deadly combinations come together, in epidemiology, we see there's a significant interaction on them that they increase the risk of mortality. In other words, when you have extreme heat happening, the effects of the Wi-Fi smoke on mortality will be much larger compared with there's no such extreme heat events. So again, heat, Wi-Fi smoke, they interact together, right? So we have to consider the different extreme weather events when we think about climate change. And another thing we did is when we look at the Wi-Fi smoke, we found that Wi-Fi smoke globally in the low and middle income countries, they can lead to significant increased risk for childhood stunting. At the same time, we found that drought exposure can also lead to significant increased childhood stunting. Then the question is, we know that when you have a drought events happening preceding the Wi-Fi events, it may make the Wi-Fi happening more frequently or more intensively, right? So the question is, could Wi-Fi smoke PM2.5 kind of explain part of the effects we see between drought and childhood stunting? Led by Jiazhanhui Li, a visiting scholar in my group, we did this kind of, in epidemiology, we call it mediation analysis. So what we found is indeed, so this SPI is an indicator for drought. The more negative it goes, the more drought it is. So we indeed found drought leads to significant increase of childhood stunting. Drought also leads to more Wi-Fi smoke. And Wi-Fi smoke leads to more childhood stunting. And we found among the total effects from drought to childhood stunting, about a quarter can be explained by the Wi-Fi smoke. So this really shows the complex mechanism. So these different extreme weather events did not just co-occurring compound with each other. They also could one lead to another, right? So how to really dive into the complex relationship between these different extreme weather events. I think it's a very active research question. But when we do this type of analysis, we always estimate how much mortality, how much morbidity attributed to this risk factor. But it doesn't answer the question. The question is, how much of the health burden we see is due to the human-induced climate change? So to address that question, one of the, I think, landmark study by Dr. Wilson Cabrera, the colleagues from the multi-country, multi-city network, which Professor Bell is a leading member, they conducted a study. They're working with climate scientists to look at the global average temperature with human-induced climate change and without human-induced climate change. So this delta is a fingerprint of human-induced climate change, right? That's the contribution from human-induced climate change. And with that, they estimate that globally, about more than 1/3 of the current heat-related mortality burden can be attributable to the human-induced climate change. So this is looking back as an attribution analysis. Working with Dr. Wisto Cabrera and the multi-country, multi-city network, we project what the future impacts will be. So looking at more than 800 locations, we use about 18 different global climate models and 2 relatively high emission scenarios. And we look at the future periods when the global average temperature reaches 1.5, 2, or 3 degrees Celsius warming. But when doing this analysis, we do not only consider the changing climate, because on the same time, our world is also aging. Especially in the developing countries, it's aging faster. So in epidemiology, the years of research has shown that older adults tend to be more vulnerable to climate change. So specifically, for example, here, the temperature mortality U-shaped relationship. For older adults, they are more vulnerable to both heat and to both cold. So you see their curves are usually the highest. So that has major implications for our future projection, because in the future, we have an aging society. Overall population susceptibility to temperature is going to increase because we have more older adults in the future. So taking that into consideration, we calculate the future cold-related mortality changes. Well, previously when doing so, many people will just argue, well, yes, cold has a significant association with mortality, and with a warming climate, in the future, we're going to have less cold days. So you have less cold-related mortality. And in some scenarios, this reduction in cold-related mortality could outweigh the increases in heat-related mortality. So some skeptics of climate change would even call this, climate change may be not a bad thing. However, I argue here that if we do consider what's the real situation here, we have an aging society. When we consider the aging population factor in the calculation, you will have this reduction in cold-related mortality largely offset by population aging. And with each additional degree warming, with more people aged, we found in our study in this about 800 locations in about 50 countries or regions, the changes in the cold-related mortality will not be decreased. It's actually a net increase. On the other hand, when we look at heat, population aging will substantially amplify that increase. So now the story is clear. You have an increase in cold-related mortality. You also have a larger increase from heat. Then combining together, the future temperature-related mortality burden will be substantially increased when we consider both climate change and population aging. The second example I want to give in the projection is air pollution. Since this is school environment, we study a lot of the air pollutant. So one particular air pollutant closely linked to climate change is ozone pollution. So here in Connecticut, we also face the ozone problem, but ozone is also during its formation with a warming temperature, the chemical reaction rate increases, and with a warming climate, we may have some more emissions from the natural precursors of ozone. like forest fires, lightning, degenerates in nitrogen oxides and YSEs. So it turns out climate change could lead to more ozone pollution, especially in the already polluted areas, like urban areas, right? So this looks like an additional penalty that climate change is imposing on us. That means even if we keep the current emission standard the same, with a warming climate, we're going to have more ozone pollution simply because of this mechanism. So this is kind of penalty on the ozone pollution, but that penalty also translates into a health penalty. Led by a former postdoc fellow, Dr. Domingo, we look at this more than 400 cities around the world and using multiple global climate chemistry models, using 4 different, most recent CMAQ-6 scenarios. What we found is that among the 4 scenarios, 3 of them here from SSP2, 4.5, we said the relative moderate emission scenario, to the 2 high emission scenarios here, we're going to have an overall increase in the ozone-related mortality. However, if we will be able to achieve the SSP 1 to 6 scenario, which is a very low emission scenario, the scenario that can actually keep the Paris Agreement alive by limiting the global average temperature increase below 2 degrees Celsius. Unless we can achieve this, ozone-related mortality will increase. So this tells us a story that, if we look into the future, actually the mitigation matters, because from the high emission to the low emission, we will achieve not only reducing the ozone-related mortality burden, but also we will actually have a net decrease for the ozone-related mortality burden worldwide. And we have another follow-up study in China, but rather than looking at mortality, we look at a cardiovascular morbidity outcome called acute coronary syndrome onset, using data from most of the major counties in China. So we consider 3 different global climate models in 2 future periods, 2030s and 2060s, using one of the high emission scenario, SSP 370, and another relatively moderate emission scenario, SSP 2, 4.5. And when we also can consider the population size change, population, the aging structure changes. And when we combine everything together, we see for older adults more than 65 years older in the future, they're going to have a much larger increase in this acute coronary syndrome onset. So increased cardiovascular disease burden in the future. And this increase will largely offset the decreases for what we observed for the younger population. So this all sounds very good because this shows us the health benefits in the future, right? And we're choosing the 2060s because that's when China promised to have the carbon neutrality goals. But again, the health benefits is in the 2060s. And as a human being, unfortunately, we tend to discount the future benefits, right? So you may wonder, what are the immediate health benefits if we do the climate change and mitigation adaptation strategies today? Well, we do have an example. If you recall, in the early phase of the pandemic, we have lockdown, stay-at-home orders worldwide. So this is a figure shows in Wuhan, quickly after its initial lockdowns. What you observe is there's basically no traffic. Because of that, and literally trying to expand these nationwide lockdowns, we can quickly see, even just from satellite images, the emissions of traffic-related pollution called nitrogen dioxide has dramatically decreased during the lockdowns. So what are the health benefits? Actually, Paul is the first person asking me about this question, and we end up working to come up with, I think, one of the very first study globally to quantify the potential health benefits of the air pollution reductions during the COVID-19 lockdowns in China. And in this initial study, we found there's tens of thousands non-COVID-19 related deaths could potentially be avoided due to that early phase of lockdowns. And after that, we have a Health Effect Institute funded study to look beyond China, utilize this kind of natural experiment that we have the air pollution reductions. And we quantified that for other regions like California, Italy, in some parts of Germany, we do see a large reduction, avoiding the mortality from this reduced air pollution. So again, we actually see the evidence shows us when we reduce emissions, we reduce air pollution instantly, and we see the immediate health benefits. So that actually has a huge implication for us to address climate change, because that means if we are addressing climate change, we're reducing the emissions. In addition to these long-term future health benefits, we're going to also have immediate, substantial public health benefits today. So in doing this research, and there are also a lot of challenges. And if we look through the lens of the health impact assessment, I think we can discuss some of the current challenges, but also opportunities for us to tackle. For example, when we think about the study population, I mentioned, in addition to the population size change, population aging is a really important factor. But it's more than that, right? Especially thinking about the racial ethnic disparities in exposure in the health burden. And when we think about the health outcome, most of the current research are quite limited to specific regions like US, China, or Europe, where you have a lot of high quality health data. But there's a lot of developing countries that don't have such data. For example, in the global study, we showed use the multi-country, multi-city network study. In Africa, we only have South Africa for the data. There's a huge data gap. Then when we look at the exposure, we're using the model outputs from the climate models. But these climate models, they're not built for health impact assessment. Nowadays, most of the global climate models give you the spatial resolution as about 100 kilometers. So this will be too costly for us to conduct any meaningful exposure assessment. So we need some downscaling techniques in order to use that. And another thing is about the lack of detection and attribution studies from climate science. Although it's emerging, there's a lot of studies, including the water attribution studies kind of collaboration. But relatively speaking, their outputs has not been well used in projecting or detecting, attributing the health impact of climate change. So this remains a very active research area. Lastly, when we think about epidemiology, although we know a lot about adverse health impact or potential health impacts from climate change, our current knowledge about the health effects of climate change is what I call still the tip of the iceberg. So there's so many things we don't know. For example, what are the long-term cardiovascular effects of exposure to drought? Right? Every year in the US, we have severe drought events happening, but what are the long-term cardiovascular effects? And as I alluded to earlier, when we think about the complex pathways from climate change to health, these different pathways don't act independently. They interact with each other, right? What are the compounding risks from multiple different extreme weather events? So these are also active research area. And when we look into the future impacts, we know it's bad, but what are the potential benefits if we act on it? What are the co-benefits of climate mitigation policies? What are the co-benefits of future adaptation strategies? So these are also another active research area. But last but not least is when we do this kind of analysis, each step will bring additional layer of uncertainty, right? So overall, how do we qualify this uncertainty and incorporate this uncertainty in our decision making, in our policy makers' decision when we want to address climate change? This also remains a big challenge. I want to give you just some of the quick examples of what our groups has been doing in facing each of these challenges. When we think about demographic change, an issue in the United States is unfortunately there's a lot of racial ethnic disparities. For example, here we constructed a nationwide heat vulnerability index among about 2/3 of the census tracts. Led by Michelle Mawa, a former master student, we actually make this heat vulnerability index map publicly available. So if you scan the QR code, it will lead you to a Yale ArcGIS story map. But when we look at the different communities, it turns out communities more Hispanic or Black, they tend to be more vulnerable to heat. That means when we look into the future, when we make the decisions, if you only look at the general population, you might underestimating some of the impacts for these kind of minority groups. Similarly, when we look at air pollution, we did another study by former PhD student Yi Chun. We look at the overall nationwide cardiovascular mortality burden attributed to the long-term PM2.5 exposure. What we found is that the non-Hispanic Black group has 3 times higher in terms of the attributable mortality rate compared to the non-Hispanic white. So there's a huge gap or huge disparity in the PM air pollution related health burden. So how are we going to project the future if we only use a general population, one single exposure response function? Most likely, we're going to underestimate the future impacts on these racial minorities. The second example is there's emerging studies showing new health outcomes that could be linked to all the climate-related factors. For example, we did a study looking at the public schools in North Carolina, and we found that long-term exposure to air pollution could lead to poor performances for students when they take math or reading tests. And similarly, it's not only about students, children. When we look at older adults, there's emerging studies showing that air pollution and extreme weather events can also lead to cognitive decline and even leading to Alzheimer's disease and dementia. So here just shows our study using a China cohort to look at older adults, and we found almost a linear association. When ozone increases, the cognitive decline or impairment increases. And then for the detection attribution, we also go beyond just the temperature. Here we did a study by my former postdoc fellow Ping Wang, who's now assistant professor at the University of Maryland, that we look at what we call temperature variability. So in addition to the mean daily temperature, the diurnal temperature range or the day-by-day temperature variation can also independently affect our health. And what the Ping found is that roughly in Africa, about 7% of the low birth weight can be attributable to this temperature variability. So when we project to the future, when we think about the historical burden, it's more than just the mean temperature changes. And lastly, when we're doing this kind of modeling work, projecting the future impacts, adaptation remains one of the huge uncertainty factor, right? So I always get the question that imagine in the future, our technology advances, all of a sudden we could have technology innovation that will elevate the heat exposure impacts. So for example, if our clothes can cool itself, then you don't need to worry about whether you are in a 40 degrees Celsius environment or 20 degrees Celsius environment. Well, that's certainly some useful assumptions, but when we actually project or look into the future, does this kind of adaptation, either physiologically or socioeconomically, does it matter? Which one plays a larger role? We did a kind of modeling analysis, assuming future heat-related mortality, the adaptation by a certain, from low to high, and sensitivity to the cold-related mortality changes. Also, we're using the GDP projection as a way to consider socioeconomic changes in the future. It turns out, this is a very messy figure, but the main conclusion is that the big changes we see is whether or not we consider the socioeconomic adaptation. So this actually has a huge implication, because when we think about the future, temperature-related mortality burden, it actually points out a very effective way to reduce that by increasing the adaptation is to improving our social economic status, to improving our current inequity among the subgroup population, among the different communities. So this might play a bigger role in help us to address the future threats from the increasing warmer climate. So to summarize, what do we see? Climate is changing. It's impacting our health directly, indirectly, and it combined with our social dynamics, population aging, etc., can impact not just our physical health, but also our mental health. And to move forward, we really need actions to try to reduce the climate change emissions and also find the best efficient ways and effective ways to adapt to the warming climate. Thank you for listening. And I also want to thank the group members from our lab and also acknowledge the funding support. Thank you.
All right, we have time for some questions.
Such a great talk. I two questions quickly. Do you mind jumping back to the global impacts map that you had on global, I think, excess mortality, the one where the whole planet was
This one?
Anyway, what was interesting was that I'm wondering whether the fact that there was only data in Europe and the United States was a function of where there's data with it or their impacts, or was it actually that there are less impacts in those other parts of the world?
So in this particular study, as you can see, we have about more than 200 cities in the United States, actually using the data from the MMaps, which Professor Bell is one of the major leading contributor to that data set. But globally, as you can see, most of the data from US, Europe, and Asia, some Asian countries.
But the lack of results in other parts in the global south are because there's no data to study it. Is that right?
I put it this way. So no kind of ready to use high quality data.
Got it.
For example, the mortality data, it's relatively speaking easy to get from Europe and the US.
Yeah.
But if you want to get data, for example, in some of the African countries, they don't even have a national mortality registry system.
Yeah. We're seeing a lot of peer-reviewed studies around mitigation that imply a lot of mitigation in the global south, but show no benefits to them of that, which could be a problem, right? So that sometimes it's useful to just point out, hey, we don't have data for this. The other question is, we're doing work on climate migration, and attribution is really important. You have great results here. Can you talk a little bit about the tension of attribution? Like, what you've shown a lot. What is attribution needed for, or what problems do you have if you have attribution? Like, who raises objections and things like that, right? Because you clearly have results.
So if I understand the question correctly, so in attributing, who's responsible for that, right? Yeah, so I think that we didn't do much of the study because it indeed includes a lot of kind of simulations that you need to run with building your own emission scenarios and run the global models and try to do that. So unfortunately, we didn't do that a lot. But I think there's some studies trying to quantify the different emission sources, where it comes from, who's more responsible. I think more research actually done in the atmospheric sciences or in school environment rather than from the school public health. Yeah, thank you.
Hi, thank you very much for your talk. My question is more about the actual slides of your presentation. But why, and I think this is important, as we talk about the face of science, you included in every citation a picture of the scientist that did the research. Can you talk a little bit more about why you did that?
Yeah, so I want to give credit to my group members. So for example, here is Dr. Domingo, this wonderful research. This is Dr. Jeban, a visiting scholar in our lab, and we have, of course, my PhD students. So I think, in at least in our group in conducting this type of research, sometimes is each individual person leading the research, and and we have the collaboration within the group and beyond the group. So I think, generally speaking, for me, it's most kind of as their mentor. I'm not doing the on the ground work, so I want to give them the credits. Yeah.
Maybe one or two more.
Thanks for a great talk. So in thinking about this, and you've shown very clearly and very beautifully and depressingly how climate change has negative impacts for human health. Unfortunately, it's fairly clear that that argument is not doing much to stop or reverse climate change. And so I'm thinking of ways in which this research could inform on-the-ground efforts to prevent some of this mortality, despite the fact that it's not helping us convince people to rein in climate change. And then related to that, I was thinking a bit about underlying mechanism. Of course, in public health, it's very hard to do ethical, controlled, randomized trials to see what the underlying mechanism is. For example, like what struck me was the increase in childhood diarrhea with drought and then flood. But if there's understanding of like, well, what is causing that? What's the underlying disease? Would it be possible to, when that's happening, to then send more medication or vaccines to that region during that time to prevent some of that mortality? So maybe if you could just talk about how this could inform efforts to mitigate some of this mortality in the face of unmitigated climate change.
Thank you. Excellent question. And also billion-dollar question. But your last point regarding, we do a lot of work try to understand both the biological mechanism and the social economic behavioral mechanism on these impacts. So we get back to the drought study. So when we do this study, we found this association between drought and childhood diarrhea risks. And we also look at all the risk factors that we call it modify the association, or we call it effect modify. That means if you have different level of that risk factor, would the risk be different? So in that study, we found several factors play a major role. For example, whether the household has access to clean water, whether when you have running water, but do you have soup or detergent for washing your hand? Or for the household, many of the women need to carry the water, but the distance from the household to the point that they need to extract their drinking water, these all significantly modify the drought and childhood diarrhea risks. We do see these kind of activities, what we call WASH, water, hydrogen, sanitation, and hygiene. These WASH practices can serve as important effect modifier. They can mitigate or reduce the risk of drought on childhood diarrhea. So one the implication we wrote in the paper is actually to boost increase the WASH practice, especially in the low income countries. But actually beyond that, we do have a lot of research ongoing, trying to understand some of the biological mechanism, especially for a lot of the cardiovascular disease. We see the heat exposure on cardiovascular disease. One potential mechanism is during heat wave, you have hot night, and hot night disrupts sleep, and the sleep quality leads to a lot of these adverse cardiovascular biomarker increases. So that was one of the pathway we're looking at in some of the other studies. Yeah, thank you. Hi, Paul.
Absolutely brilliant body of work. Thank you so much. So I think it might be the first time that I've ever slightly disagreed with Liza. and I say slightly because the point about those of us in this room know how critical climate change is to health. I'm going to suggest that the outrageous majority of people don't view climate change as a health issue, and health is not centered in climate change. It's an environmental issue. Some people think it's an economic issue or whatever. But this body of work really centers health. People don't generally I'd love to know what our Climate Change and Communication Center would say about this. But I don't think people, when they hear climate change, they think it's killing people and making them sick. I think that they view it differently. So my question is about communication. When you have this body of work, what ways of centering health in the whole climate change discussion, what mechanisms do you think are necessary in order for it to have a central role in climate change policy as opposed to a peripheral role that I think only folks involved in the field really understand?
Thanks, Paul. Yeah. Actually, speaking of the communication, speaking of the mission, this Yale Center on Climate and Health, our aspirational goal is to put health at the heart of climate actions. So this couldn't be done without a communication, and we do want to work with the program on communication here at Yale, but also broad communities, journalists, etc. Try to not only disseminate our findings, but to actually engage with providing some of the policy briefs, things like that, to try to increase the awareness of the health effects of the climate change, also health benefits of us taking any actions. But in terms of, really this is, I totally agree with you. This is a challenge, but it's much needed work, because if the general public still views climate change, the first image they think of is polar bear. It does not motivate them. If you think about climate change as the health, the cardiovascular, the heart health of your parents, right? The mental health of your fellow colleagues, and the birth outcomes of your loved ones. If that's make it a health personal story, that may motivate people more towards the action. Thank you.
All right. I think that's all we have time for. One last round of applause.
Thank you for coming.